Good evening, everyone. We want to welcome you to our Tuesdays with the Doctor. My name is Elder Annette Barnes, and we want to welcome those who are with us on Zoom as well as on Facebook Live. We're just happy that you're joining us this evening. We have a special guest tonight that is going to talk to us about general medicine, specifically health maintenance and vaccines and various things like that. And we hope this will be helpful to you as well as to someone that you know. Our speaker will give us the presentation first, and then we will take questions afterwards. And you can ask questions after the presentation either by unmuting yourself or putting your questions in the chat during or after the presentation. Those who are with us on Facebook can put their questions in the comments section. We will be monitoring that and we will ask your questions from there. If you would like to ask a question anonymously, you can send them in the chat directly to me, and I will ask the question for you. At this time, I would like to introduce our special speaker this evening. Dr. Jacqueline McLean Bennett specializes in family medicine. She practices at the Troy Family Health Center in Troy, New York. Dr. McLean Bennett matriculated at Philadelphia College of Osteopathic Medicine. Her internship was at Bassett Medical Center and her residency was at Ellis Hospital. I was actually reading her reviews online this evening as I was pulling this together, and she has 4.9 out of 5 stars. So I was very impressed with that, especially since she is also my primary care physician, and I happen to agree with the high reviews. So at this time, it is now my pleasure to turn the time over to Dr. McLean Bennett. Welcome.
Well, hello, everyone. Thanks so much for joining us. Like Annette said, I'm a family practitioner. I've been practicing in the Capital District for about 22 years now. And I'm married with 2 daughters, and one of them is actually a nursing major. She goes to Liberty University in Virginia, and my younger daughter is at Algonquin Middle School, super active in lots of sports. Some of my passions with family practice are health maintenance, and I'd like to go over just a couple of those with you tonight. The first one, which is probably the hottest topic right now, is vaccines. Let's go with the less controversial ones to the more controversial ones from here. All adults really should have a tetanus shot. Remember those tetanus shots, the one that gives you a sore arm for a day? People that maybe have grandchildren or that have young kids probably have had their tetanus shot up to date. It's not really the tetanus part of it. It's more that pertussis or whooping cough part of it. That's super important. Probably about 7 or 8 years ago, we saw an uptick of pertussis in the capital region. And we, as primary care doctors, were very proactive about trying to get everybody up to date on their tetanus shot. We do give them to pregnant women and the last trimester of their pregnancy because these little babies were getting pertussis. And that's why I say those grandparents and the people that have young kids at home probably have had their tetanus shot up to date. Like I said, it's really not so much the tetanus part, but that pertussis part that everyone really should speak with their doctor, making sure that they have that done every 10 years. So that's probably the least controversial one out of all of them. The next one is the pneumonia shot, is also a very common one for adults, the Pneumovax. It has 23 of the most common strains of pneumococcal that we see in community-acquired pneumonia. Community-acquired pneumonia is the one that you get just walking through the grocery store or going to work or, being at the drugstore or anything. It's just very commonly found in the community. Patients that have any major medical issues with lung or diabetes, hypertension, hyperlipidemia, high cholesterol, any asthma, COPD, anybody that's a smoker, absolutely over the age of 18 should get a pneumonia shot. And then you get one, and then you get another one after the age of 65. All patients over the age of 65 should definitely get a pneumonia shot due to the fact that not only are they at increased risk of getting pneumonia, but being very, very ill from pneumonia. So that's the second one. Not a lot of side effects to the pneumonia shot, unlike the tetanus shot where you have that sore arm. The next one is the flu shot. It's a little bit more controversial. Some people get them every single year, and some people say, no, thank you. Once again, as physicians and providers, they should offer that to you every single year. Usually we start in late August and go all the way through to either January or February, making sure that we decrease the amount of flu that we see. Obviously in the Northeast, the flu can be pretty bad. There's multiple different types of flu shots. There's just the regular one. They also have another one called a flu block for patients over the age of 50, or if you're over 18 and have a lot of medical issues, you can get that one. And then we have the high dose flu for the patients over the age of 65. It's so easy to get a flu shot. You can go to the pharmacy and the pharmacist will probably ask you, can I give you a flu shot? There's lots of supply of flu shots. We haven't had a flu shot supply problem probably in the last 5 or 6 seasons. We're really trying to get everybody who's willing and able to get a flu shot to get one, especially with COVID being around. We don't want to have people getting the flu and COVID like we did last season, which was awful. Definitely decreases your morbidity and mortality if you have them both at the same time. Flu shot, sometimes people get low-grade fevers or little body aches. Sometimes you get a sore arm from the flu shot, but I promise you, you do not get the flu from the flu shot. If you're going to get the flu, it was because you're already exposed. The flu shot takes about 2 to 3 weeks to start working, and that's the reason why we start giving it in August, September, October, even though flu season doesn't start until November. It takes a couple of weeks to start working, and it usually lasts the whole season. So obviously patients that are over the age of 65 really need to get the flu shot. Those are the patients that die from it. We do start offering it at 6 months and all the way through. I am a huge proponent of the flu shot. The less flu that we have out in the community, the better it is for our community. Even if you have an intact immune system and you get the flu, my biggest plea to you is if you feel ill, please, please, please stay home and don't spread it to the rest of the community. The good thing about the flu is when you're ill from it, you usually become ill very quickly. So it's one of those where like, I'm definitely sick and just stay home. Right now, unfortunately, a lot of the symptoms are very similar to COVID. And like I was talking to Annette earlier, all of the urgent cares are flooded with people getting COVID tests, and they don't really have that much more room for these flu testing. So if we can get everyone to get a flu shot, that would be great. The last, probably the most controversial of all, is the COVID vaccine. There's lots of political things, religious things that are going along with the COVID vaccine. Anyone that's been in the medical field, pretty much most of us, were scampering to get vaccinated against COVID back in December and January when the vaccines first came out. Then as it rolled out to everybody else, right now we're kind of just scampering to get as many people vaccinated as possible. It's not an easy shot to take, and if you've spoken with anybody, there's lots of side effects to the vaccine. For sure, all 3 of them, whether it's the Janssen & Janssen one, that's just the one, the Pfizer or the Moderna, there's lots of side effects to the COVID shot. However, what we're seeing now is the long-term effects of having COVID so far outweigh the risks of the vaccine that we as a medical community are really still pushing and recommending it for everyone 12 and above. So everyone pretty much knows, you know, the ins and outs of that. Once again, the COVID vaccine now is extraordinarily and widely available, just like the flu shot. You walk into any pharmacy, and pretty much every pharmacy has the COVID vaccine. If you're interested in getting it, you can just call the pharmacy ahead of time, or a lot of times they just allow you to show up. They are recommending right now for patients who had the Pfizer vaccine, the third shot or the booster shot is now being offered for everyone over the age of 65 or anyone that has any medical issues. So if you did have that Pfizer vaccine and it's been more than 6 months since you've gotten your first one, they are suggesting you get the third one. Right now, there's no indication for anybody who had the Moderna or the J&J to get any boosters as of yet. So those are the 4 big vaccines that kind of broad stroke the majority of adults. There are some other ones too, but those are really the big ones that I wanted to touch upon today. So that's vaccines. Next, we're going to move on to colonoscopies. Colonoscopy is colon cancer screening. There are other ways to do colon cancer screening, but the United States Preventive Task Force has just lowered the age for colon cancer screening to start at age 45. That's a brand new recommendation within the last, I think, 6 months or so. So right now, colon cancer screening should start about at the age 45 and go to the age of 75. Whether it be a full colonoscopy, if you have any family history of colon cancer or colon polyps, it should be the full colonoscopy. There's also other FIT tests. Everyone knows what the Cologuard is. If you watch TV at all, they have the little FIT test, which is the box, the colon cancer screening in a box. Your primary care doctor or any of your doctors can order the Cologuard test for you as long as you don't have a family history of colon cancer. It's super social distanced, I say. What they do is they place the order, the box comes delivered to your house. You take it in your house. I always tell patients to open up and look at all of the instructions, take the box and put it in your bathroom. The next time you have a bowel movement, you follow the instructions, put everything back in the box, and you leave it out front of your house, and UPS comes and picks it up on your front doorstep. So in the time of COVID is a great social distanced way to get your colon cancer screening done if you don't have that family history, and you do it every 3 years. So it's not even something you have to do every year. And as long as that's negative, that's a great way to do your colon cancer screening. So those are really the 2 suggestions for colon cancer screening. And that's pretty much everyone, men, women, between the ages of 45 and 75. And you can speak with your primary about getting that done. The next are really for women, mammograms. Once again, United States Preventive Task Force says to start at age 50. Between the ages of 50 and 75 for mammograms, and do them every other year. Most OBGYNs in the College of Radiology, American Academy of Family Practice, usually start at the age of 40 and usually order them yearly. All the insurances pay for them yearly. And that's the way that I practice. So either way, 40, 50, up until the age of 75, mammograms are super, super important. The early detection, women can live with breast cancer if they have early detection way, 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 way before, even if you're doing monthly breast exams, which we actually don't even suggest anymore. So that's for women and mammograms. During COVID, there was a little bit of a backlog as far as mammograms went because people not wanting to go in and having staff issues and things. There was a little bit of a backlog. I think most of the radiology places have caught up on that backlog, and you should be able to call and get your mammogram done within weeks now, rather than waiting months now. Next one is pap smears. Once again, this is for females. For women age 21 to 65, that's a cervical cancer screen. The current recommendation is every other year from 21 to 30, and between 30 and 65, recommendation is every 3 to 5 years as long as your paps have been normal. That one, either your primary care doctor or GYN can take care of that for you. Most of us older women can say, thank you very much that we no longer have to do that yearly. We used to have to do it yearly, but it's kind of a nice thing. As long as they're normal, we can go and spread that out a little bit. The next thing is EKGs. This usually is part of your yearly full physical. I ask for my patients to come in either yearly or biannually for your full physical, starting at age 18 and going all the way up until indefinitely. For my patients over 65, I absolutely want to see them every calendar year for their Medicare wellness visit. For all my patients over the age of 50, I do EKGs. It's a good idea to have a baseline because a lot of people have different cardiac rhythms. EKG is when they put little stickies on your chest and take a look at the electrical activity of your heart. And a lot of people have different ones. So to get your baseline done at 50 and have them done yearly or biannually is not a bad idea, to make sure that there's no background changes that have happened with that. So there's that. Trying to think what else. A lot of people ask about for men, things like prostate antigen levels. We no longer do those routinely unless you're having symptoms. That's a prostate test. And that's just not done as often. A couple other things that we usually talk to patients about are making sure that they see the dentist every year, get their cleanings done. So that's really important. And also eye exams, especially over the age of 65. Every single person over the age of 65 should go yearly to see their eye doctor. And between 18 and 65, at least every 2 years, if you're wearing glasses or if you ever have any vision problems, you should be doing that. I think that's all I have. So I guess we can open up. Did I talk too fast?
Oh, you were great. You were great. Thank you. I
Okay.
before we get into questions, and if folks have questions, they can put them in the chat, or if you'd like to unmute yourself. But is there anything that like tends to really bother you in the sense of you see it kind of all the time, or you wish patients would like, ask you a certain question or tell you a certain thing that they just don't bring up, or a common thing that people just don't do that you wish, either preventive wise or something like that, like your pet peeve,
Mhm.
I guess, for
Well,
when
the,
people
the
come into
biggest
the office.
issue that I would say is when I prescribe a medication for someone and they just don't take it,
Oh,
or they take it once and then they just never take it again because they had a reaction or they didn't like the way they made it feel. They didn't like the way it made them feel, and just stop taking it without calling me and say, yes, Dr. Bennett, I didn't like the way that this made me feel. Is there something else? Or I took it and I had a lot of side effects. Is there something else? Or so just stopping the medication without calling me and letting me know that they had an issue with it. They come in to see me. Oh yeah, no, I didn't take the blood pressure medicine. I didn't like it, or I had side effects. So I would prefer a phone call for that. So that's one part of it. And I would say the other part which I see a lot in my practice is, oh, I didn't have any refills, so I just stopped. Okay, so
mm.
can you call me and just say, oh, Dr. Bennett, I'm not seeing you until 6 weeks from now, but I'm out of my medicine. Can you call it in? And 99% of the time it's yes, absolutely, I'll call your medicine in. So those I think would probably be my biggest issues, is stopping medicine without letting me know, or running out of your medicine and not either having the pharmacist call me for a refill or calling us here saying I'm out of my meds. Are
So
those
that's
are
a
those the answers? Yeah.
Yeah, no, that's good. That's a really important thing because sometimes you start taking medicine, then you feel good, and then you just, you feel like you don't need it anymore because you're feeling better too, right?
Yeah. 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 Yeah, well, some medicine you can do that with, but there's some medication that you probably should ask before you stop. Because if you're taking this medication, and like say it's a blood pressure medicine, and you're like, oh, well, my blood pressure is normal, so I'll just stop it. I'm like, well, the blood pressure medicine is not like an antibiotic. An antibiotic, you're sick, you take the antibiotic, and it gets you better, and then you can stop it. But blood pressure is more of a chronic problem. So with blood pressure medicine, it only works while you take it. If you stop the medication, your blood pressure is going to go back up.
Hmm.
Same thing with cholesterol. A lot of people are like, oh, my cholesterol looks great. I'm going to stop my medicine. No, it looks good because you're on the medicine. And if we stop the medicine, it's going to creep back up. So once again, there are some of those chronic medications. A lot of people feel that, oh, no, my blood pressure is fine, so I can stop my medicine. Or my cholesterol is really good, so I can stop my medicine. Not really like that.
So for something like blood pressure or cholesterol, especially, if somebody is changing their diet or doing exercising or starting something, improving their quality of life, shall we say, while they're on this medicine and it goes
Lifestyle,
down,
yes.
like like
Lifestyle, yeah.
lifestyle. Thank you. Their lifestyle. Is that possible to get off the medicine, and how would you know?
It, sometimes. So
Okay.
if you're one of those people that don't exercise and kind of just eat whatever you want, well, I go to McDonald's or I go here, or I go there, or I eat a lot of ice cream, or I'm just not exercising at all, and your cholesterol is really high. And you're like, okay, I'm going to do some lifestyle change. I'm going to start exercising. I'm going to cut out McDonald's and I'm going to eat cleaner. I'm going to eat more fruits and vegetables and things like that. I'm going to clean up my diet. The majority of those people can probably come off the medication. But if you're already exercising every day, at least, 30 minutes, 5 times a week, and you already have a really clean diet and you think you're going to clean it up even more, it's probably not going to happen. It's probably your cholesterol is family history, and you're probably not going to be able to come off the medicine.
Okay, so that's really good information. So what I kind of hear you saying is that if you make a change in your lifestyle and it's significant and it's taken, it's over a course of time, that we should talk with our doctor first and explain what
Sure.
we've been doing before trying to
Yes.
change something else
Yes.
like getting off of medication. Okay.
Correct.
All right, that's great. Okay, so we have some more questions, and once again, I want to encourage you to anybody who wants to put them in the chat or on Facebook if you're watching, if you have questions for our family doctor here. We've been talking about general health maintenance and vaccines and things. I know I see some people joining us on Facebook, so welcome. But we have a few questions here, and one is finding a primary care doctor can be a daunting task for some. From a doctor's perspective, what encouragement can you give for someone who may be looking for a doctor or not sure about how to find a specialist for some of the yearly, bi-yearly checks that were mentioned this evening? How do you even start?
Um, so that question comes a lot up for patients who are moving, usually. Like, oh, do you know someone that lives in, like, the Palm Beach in Florida? I'm like, oh, no, I don't. Um, the best way to do it is start speaking with your colleagues and neighbors or colleagues or people that you work with. Do you have a family practice doctor? Who do you see, and do you like them? What do you like about them, and what do you not like about them? And start asking questions to people around you. Ask your neighbors, who's your primary doctor? Do you like them? I know I see it a lot on Facebook, and sometimes I cringe when I see that on Facebook because I see a lot of doctor bashing, which I don't like
Mm,
because I don't think that that's really the place for it. So I usually don't suggest opening it up on Facebook saying, tell me who your doctor is, because I always cringe at that one. But definitely having that conversation with people that you work with, people that are in your neighborhood, and ask them, what do you like or what do you not like about your doctor? Because I know for me right now, I'm trying not to accept any new patients because my practice is so full. But I have doctors that I work with that I would love more people to come in and see. We are accepting new patients here, and I have two great nurse practitioners and a new female physician here, and we're accepting new patients. So if you're in Troy Family Health, they are accepting new patients. I am not, because my practice is super full. And I know my patients, it's hard to get in to see me, and they would probably say, well, she's a great doctor. However, it's just really hard to get in to see her. But I think that's the first step that I would do would be ask neighbors and colleagues and stuff.
One of the things that I've also heard is somebody who's had their doctor their entire lives, basically, or many, many, many years, and then they retire. and then they have to find somebody new who has not had that whole history.
Yeah,
You know.
that is super tough, especially because I know, I mean, I've been practicing for 22 years and I have a lot of patients that I've been seeing a huge chunk of that time. And I don't think that any of them look forward to my retirement. I mean, I'm still young, so it's going to be a while. But I know that I've had patients that have followed me to the multiple different practices. And yeah, that's tough. When you've seen someone for 10, 15, 20 years, you know them so well, like that half of the visit is just catching up with, oh, how's this person doing? How's this person doing? So yeah, that is very hard to have to reestablish with someone who doesn't know you, because you really want someone that is going to take the time to get to know who you are, not just your high blood pressure or your cholesterol or your diabetes, but they really want to know who you are too. And sometimes it's hard in today's um, healthcare environment to take the time to do that. But I just think that that personal connection is just so important. People don't care what you know until they, what you know until they know that you care about them first.
Yeah. So I have a question. You were talking about all these, different things, the colonoscopies and the mammograms and all that, but you were mentioning up until 75. What happens after 75? Something magical happens after that?
So these are health maintenance things that we're doing to um, not only prolong your life, but also to catch disease very early so that your quality and quantity of life is increased. After the age of 75, sometimes the risk of a colonoscopy is greater than the risk of you actually developing colon cancer after that. Because that 45 to
Oh,
75, that's the biggest age range where you're going to develop it. And after the age of 75, it takes like 5 to 10 years for the colon cancer to get really bad. And by that, 85, we're not really preventing disease. We're just kind of treating disease at that age. So, and the same thing with mammograms. Between 45, or 40 and 75, after the age of 75, a lot of women have been, 20 years post-menopause, and a lot of the breast cancers are estrogen and progesterone driven, and most women by the age of 75 no longer have a lot of estrogen and progesterone, and the chances of them having breast cancer over the age of 75 are so low that the risk of having that mammogram and finding something that's not really needing to have anything done to it, finding something like, oh, well, that's just something, but it's not really cancer. It's just, once again, you have to weigh the risks and the benefits, and the risks really far outweigh the benefits. Same thing with pap smears after the age of 65. Most women postmenopausally, if you've had 3 pap smears that were normal prior to them, we just don't see cervical cancer over the age of 65 with someone that has had normal pap smears. You just don't see it. So
all
that's why
right.
we stop at those certain ages.
It's good to know. Good to know. Once again, I want to encourage people, if you have questions, to put them in the chat, or you can unmute yourself and ask them. I want to go back and talk about vaccines a little bit. I know you mentioned that the booster shot is now available for COVID-19 for those over 65, and you can receive that the same way. You can go to a pharmacy or anywhere that provides that and just walk in, and
Mm-hmm.
they'll check your age or whatever, your eligibility, and so there's nothing unusual about that than the way we got them the first time.
Correct. It's 65 and older, so it's only just the Pfizer ones.
Just the
So
Pfizer.
just the
Okay.
Pfizer ones, and it's 65 and older, residents of long-term care settings. If you're 50 to 64 with underlying medical conditions,
Okay.
if they're 18 to 49 underlying medical conditions, I'm just reading off the New York State Department of Health that I printed out.
Every few days, something new is happening, right? So you have to.
For sure. People age 16 to 18 to 64 who are at increased risk for COVID-19 exposure or transmission because of occupational or institutional settings. So that's like teachers. So anyone that is in a setting where they're seeing, multiple people every day. So I think that that's going to include people in the medical field and teachers because they're exposed to these kids that couldn't get vaccinated. The under 12 kids are not.
Right.
So that does include those also.
So I have a question about the pneumonia vaccine. Some folks who got pneumonia also, or who got COVID also got pneumonia at the same time. We've seen that happening. Would a pneumonia vaccine also to help prevent that, or would that be beneficial, or you know?
So the pneumonia that people got with COVID was COVID pneumonia.
Oh,
Not the pneumococcal pneumonia. Most of the pneumonias that we saw with COVID were actually a COVID pneumonia, and it had a very specific appearance to it on the chest X-ray, and it's pretty telling when you see it. You're like, oh, that's COVID pneumonia. So it's really because of the COVID that caused that. So the only thing that's going to help prevent that is actually the COVID shot should decrease your chances of getting COVID and getting COVID pneumonia. But the pneumonia shot will decrease your chances of getting all of those pneumococcal strains, the
okay.
23 most common community acquired pneumococcal strains. That's what the pneumonia shot will decrease your risk of.
Interesting. Okay. The flu shot. Last year, everybody realized that people weren't getting the flu either, because everybody was home
Masked,
and wearing
home.
masks.
Yep.
Can't we just keep wearing masks and then not get the flu too? But my question really is, uh, don't they do the flu shot off the strain that was previous year? And since there
Yeah,
weren't as many people,
we did have flu. It's their best guess, for sure. It's not 100%. It's usually their best guess. And if they're wrong and you still get the flu, it's a much milder case of it. And that's usually what happens. Oh, I got the flu shot and then I got the flu that year anyways. Well, it was a much milder case that you would have gotten because even if they get it wrong, it's still better than nothing because the people that don't get the flu shot usually become very, very ill. And if you get the flu shot and you happen to get like maybe a case of it, it's usually pretty mild.
okay. And a lot of people, anecdotally will say, "Oh, I got the flu shot and then I got the flu right after that." So what does that mean? Because they got sick right after that. So they are associating that with the flu shot, which is a lot of the reasons why people don't get the flu shot.
Right. So, depending on what it is, if it's you get the flu shot and the next day you feel a little bit ill, similar to what happens with the COVID vaccine, the next day you're not feeling so great. It's actually congratulations, you actually mounted an immune response. So, if it's just a little bit of an illness a day or two afterwards, it's because your immune system was actually responding to the flu shot. Although the flu shot is not a live vaccine. It does have 4 different strains. They're all quad vaccines now, the A's and the B's that it's getting you. It's helping to protect you against. A lot of people's immune system, that's how it responds. It's you get, low grade temperature, some body aches, cough and chills, and then it just gets better. For that, right after the flu shot, that's not the flu. That's just your body mounting an immune response. If within 2 weeks of you getting the flu shot, you actually get the flu, you were probably exposed to it prior to getting that vaccine and you would have gotten it anyways. Because it does take that 2 weeks for the vaccine to start working and to protect you against the flu. So you probably would have gotten it anyways, whether you got the shot or not.
Okay, good to know. But the shot, if you do get the flu, the shot does help keep you from getting it as bad as you would have.
Correct. Yes, it's almost always a much milder case of the flu if you happen to get the flu after having the flu shot.
And so this is similar to like the COVID vaccine, right?
Correct.
Where you may have some symptoms afterwards, but it's not COVID. And if you do get COVID afterwards, it's much more mild than if you had not received the vaccine.
In the majority of cases, absolutely. So in the pretty immune compromised population, that's why we had suggested they get their boosters. I think we started them in August. We wanted them to get boosters because we saw a lot of breakthrough in those immune compromised patients. So we definitely want them to get those boosters because they're still getting sick. Whereas the healthier patients that got vaccinated, it's usually just it's a much more milder case of it.
Okay, all right. And what's interesting, what we're hearing with between the COVID vaccines and the flu shots, and you can confirm this perhaps, is that the COVID vaccines have a very high percentage. It's like in the 90s, right, of helping to prevent you from getting COVID. And the flu shot has a much lower percentage rate of that. Is that correct?
Well, it was when they first came out. So the flu shot is about 70+% effective at decreasing your chances of getting the flu. When the COVID shots first came out, they said that they were about 90 to 92% effective. As they've been rolling out, the Moderna is still about 90 to 90%, about 90%. The Pfizer, I think, went down to about 82%, and Janssen went down to like 79%, which was about the numbers. So the J&J, obviously, it was only one shot, decreases your chances, about not as much, just shy of 80%. And then the Pfizer one was closer to like a low 80s, whereas the Moderna is still up there in the low 90s. When it first came out, it seemed when everyone was getting them, it was closer in the higher 90s. But as we were rolling it out across more and more people, the percentage went down a little bit as far
So
as
do you
not getting it.
not getting it, right, right.
Mhm.
Although not going into the hospital and not dying is still pretty high with all of those.
Yeah, so they are definitely keeping an eye on the vaccinated versus the unvaccinated. It's right now about 25% of the hospitalized patients are vaccinated, but they're almost all of them have a lot of medical conditions. They're not relatively
Mm.
healthy people. It's really rare that you see a relatively healthy patient who is vaccinated that is getting admitted to the hospital. It's someone who has underlying conditions. Even if they are not vaccinated. If you're otherwise healthy with not a lot of underlying conditions, if you do get vaccinated and get COVID, it's usually a very short-term, self-limiting disease. But if you're over the age of 65, or if you have any underlying conditions, you're usually much sicker, whether if you've had the vaccine or not. Usually, like I said, it's about 25% vaccinated and 75% unvaccinated are the ones that are in the hospital in the capital district. And I think throughout the rest of the country, it's closer to 80% unvaccinated and 20% unvaccinated, just because New York State has a higher vaccination rate than a lot of the other states in the country.
Okay. So Johnson and Johnson was in the news a lot, and I know some people are kind of shying away from that or concerned that they got that one instead of a different one. Do you have any concerns about any of the specific vaccines?
Um, well, the J&J one, there's a very small increased risk of developing a blood clot, I guess, in females. To be honest with you, I was concerned about the blood clots in general, and I had all of my family members take baby aspirin while we were doing that, and really taking the baby aspirin when the COVID numbers were super, super high around here, because that is one of the issues with COVID is the risk of blood clots with it. It's less of a risk with the vaccine than it is actually getting COVID. If you get COVID, that is one of the problems, is these little micro blood clots or these big blood clots, PE, DVT, the blood clot in your leg, blood clot in your lungs. But you can get that with the vaccine. So I usually suggested anyone that was going to get the J&J, just start a baby aspirin a day before you do it and continue it for a couple of weeks afterwards. And a lot of times that would, and I was telling a lot of patients to do that baby aspirin a day during really high spikes of COVID, just to help, just in case they were to get it, that would actually decrease your risk of blood clots with it.
Oh, very interesting. Very interesting. We have another question about the flu shot. And the question is, if you get the flu shot every year, does it give you greater immunity throughout the years, or it does?
Yes.
Okay.
Yes. There is studies saying that the people that get the flu shot every single year have the lagging immunity. So if you get it every year, it's more likely to last the entire 12 months rather than if you only get it every couple of years. You usually lose that immunity. So if you have a late flu season, like in April or May, all of a sudden these flus start popping up, most likely the people that only get their flu shot every couple of years won't have that lasting immunity, and it'll only last, the 6 months or so. Whereas the people that get it every year, they do have this lagging immunity, and they're less likely to get the flu. Hang on a second. Sorry, my husband's calling me. They're less likely to get those later flus. Sure.
Okay, so getting the flu shot sporadically is not really the best plan for overall.
I'd rather you get it sporadically than not at all. But the ones that get it every year definitely have better chances, decreased chances of getting it at all.
Okay, so even though the strains are slightly different every year, it still helps with that, having it had it the
There's
previous
usually,
year.
yeah, there's usually an overlap
Okay.
in the years, because usually from year to year there's an overlap in the kind of strains. It's not 4 brand new strains every single year. There's usually an overlap. Maybe the A is the same and maybe the B might be a little bit different, but with those 4 different strains, there's usually 1 or 2 of them that are the same from year to from last year.
So the flu shot could last you a couple of years, essentially, like for that particular strain. Is that kind of the thought?
Maybe,
Okay.
but we still say get it every year.
So are there any downsides to getting any of these vaccines that you spoke of?
Well, the COVID vaccine, it's not an easy vaccine to take. I had the Moderna. I was very sick the next day. I lost a whole Sunday because I was in bed. They're not, the COVID vaccine is not easy to take, but definitely the risk of it certainly outweighs the benefits. Or I'm sorry, the benefits certainly outweigh the risks. Sorry, other way around.
Other way around, yeah.
A tetanus shot is only every 10 years. You get a sore arm for a day. That would be the biggest downside. The pneumonia shot, no really downsides of taking it. Once again, risks and benefits. The flu shot, there's very few people that have real true allergic reactions to the flu shot. I do have a few here and there, but it's very, very rare that you have an allergic reaction. But really no downsides to it.
Okay, great.
And it not only helps to protect you, but it also helps to protect the community around you, which I feel very strongly about doing that. Same thing with the COVID shots and the tetanus shot, pneumonia shot. If you don't have pneumonia, you're not going to pass it on to somebody else. If you don't get pertussis, you can't pass it on to somebody else. If you don't get the flu because you've been vaccinated, then you can't pass it on to somebody else. Same thing with COVID, decreases your chances of passing it on to other people. So a lot of these vaccines are very community oriented. So if you want to have a good community mind and spirit, to protect not only yourself, but also all the people around you. I think that that's really, really important.
Okay, great. Well, thank you so much. I have another question here. Um, uh, on TV, all the doctors' TV shows, when somebody has a problem and they have all these conditions, they have a whole team of doctors of every specialty come in and talk over them and talk with each other, and then they fix them. So in real life, if you have multiple issues and you have multiple doctors, how do we get them all in one room? Or how does that communication happen? So it's not like I talk to one doctor and then 2 months later I talk to a different one, and then a month later or 3 months later I talk to another one, but then they're not available and they had an emergency or something. So then it actually ends up being an extra month later that I talk to them. In the meantime, I'm having multiple problems, and I don't know if I can do this thing because I have to talk to 5 doctors first, who for some reason are not magically in the same room like they are on television, all at the
I,
same time.
Absolutely. And maybe we need to talk to Hugh Laurie House. So yeah,
Yeah.
absolutely. And I love that show, House, which, and it would be great, but that's definitely Hollywood. That does not happen in real life. Maybe if you go to like the Mayo Clinic or something, it does, but certainly not in upstate New York. That's not how it works. Um, so communication between doctors, that's tough. We are all so super busy, and it's super tough. Now I know with St. Peter's Health Partners, what we've done in the last 6 months is that 3 months we are now all along the same system. We went and we changed to Epic. Epic is our computer system now. So every single person that is in within St. Peter's. So if you see someone at St. Peter's, or if you go to Memorial, if you go to Samaritan or Sunnyview, or anyone that's under St. Peter's Health Partners, now all of us are on the same computer system, which has really helped to escalate and help with communication between doctors. I can just send another doctor that's in St. Peter's a quick message, and they get back to me, because it'll be right on their computer system saying you have a message, you have a message. So you kind of can't ignore it. So it's actually really nice, and to get I saw my endocrinologist and they did my A1C. Can you take a look at it? Sure, I can pull it right up. Or I saw my GYN and they ordered my mammogram. Can you look at that result? Sure. I had my ultrasound done over at Memorial. Do you have that? So it's really a great way as a primary care doctor to see everything that the specialists are doing when they went to the emergency room, if they were at Samaritan or if they went to St. Peter's. I have all of that information. I can see when one of my patients is admitted in the hospital, it says, oh, the patient's been admitted, and I can see right where they are. So that has been a huge help. At least I know within all of our system, to be able to see what's going on, and everything is all together in one. Obviously with Albany Med being the only other big place, we're not on the same system as Albany Med, and hopefully someday we do, so we can
Mm.
interface that also. Um, but in a perfect world and in Hollywood, that's great. And I would love to see more of that happening, but I think very slowly we're going to be getting there. And I know that the administration at St. Peter's is absolutely looking toward being that way and being able to open up lines of communication between primary doctors and all of the different specialists so everyone can get on the same page, and in a great healthcare system. That's definitely what we're moving toward.
Wonderful. Well, thank you. Yeah, it's hard to know sometimes as a patient how to try to facilitate that because, a few months can make a difference depending on what the situation is. So
For
definitely.
sure.
Well, really, really appreciate your time. I do not see any other questions here at this time. So I'm just going to thank you for participating with us tonight and for all the information you gave us. That was wonderful. We want
Oh,
to thank everybody for coming tonight. Hopefully it was helpful to you all and you learned something. And we want to invite you all to our next event, which is the End of Life Planning Seminar with Dr. Vaughn James, who will share information with us on Sunday, October 10 at 6:30. Things that you just need to plan for yourself and for your family to know what your wishes are, especially as we approach the end of life. We are also hosting a blood drive with the Red Cross on October 12th from 1 to 6 p.m. at our church on 600 3rd Avenue in Troy, New York. And we want to encourage everyone to sign up for a time to give blood. And you can sign up for a time slot for the blood drive at the Red Cross's website. You can look for the Joy of Troy Church there. And other information for the other events that we have and the ones discussed tonight can be found at our website at joyoftroy.org. So we would just want to wish everybody a wonderful evening. Good night.